Hello everybody, hope you're making through this pandemic. Today we're going to cover local anesthetics pharmacology. This is a topic that is very important to anesthesiologists because these are medicines that we use every day and it's what we use to induce the anesthesia and analgesia that our patients expect from us. The information contained herein has been compiled as part of UK Healthcare's patient safety evaluation systems, is deemed to be patient safety work product, and is privileged and confidential. I have no financial disclosures to report. The primary reference for this lecture is from the 7th edition of Clinical Anesthesia by Bauereis. This lecture will cover several different learning objectives, including the mechanism of action of local anesthetics and their site of action, the pharmacodynamic properties of local anesthetics, local anesthetic additives, the pharmacokinetic properties, toxicity, and we'll do a brief slide on Exparel. So we'll start off with this funny cartoon that I found that I find pertinent because usually when I talk to my patients about local anesthesia, this is kind of what I envision them thinking in their head. So as we get started on the lecture, I want you all to keep in mind that this is a thorough review of local anesthetics, but by no means is this an in-depth or complete review of local anesthetics. So we'll begin by what is a local anesthetic? Local anesthetic, for all accounts, is a weak base with an alkaline pKa value that is greater than physiologic pH. Remember, physiologic pH is 7.4. Now there's a couple properties that all local anesthetics have in common. One of these properties being a lipophilic aromatic benzene ring. Now, depending on what's attached or the exact type of ring it is what determines what kind of local anesthetic it is. But just keep in mind, in general, there is some sort of lipophilic aromatic benzene ring, as well as a hydrophilic tertiary amine. And then the two are joined by a hydrocarbon chain that's either an amide or an ester, which is, by their names and what you guys already know, is what determines the type of local anesthetic that it is as far as it being an amide or an ester. So since we're kind of on that topic of amide versus ester local anesthetic, we'll kind of just briefly name a few just so as you go through the lecture you kind of keep them in mind which is which. So an ester are, like what I have listed, are procaine, chloroprocaine, cocaine, tetracaine, and benzocaine. Your amides are the others, like lidocaine, prilocaine, mepivocaine, bupivacaine, ropivacaine. Now the easiest way to remember this, and this, believe it or not, shows up on test, is the question will say, all of the following are amides except. Well, the easiest way to remember that is all amides have two I's in their name. If you remember that, then you got an easy question that you just answered on the test. Let's look at the ester local anesthetics. These are commonly metabolized by plasma cholinesterases, or more specifically pseudocholinesterases. A couple things to keep in mind: there's no cholinesterases in the CSF, and if somebody has an abnormal pseudocholinesterase, like a pseudocholinesterase deficiency, you got to keep in mind that these people may be at risk for toxicity. Now, another common question that will show up relates to allergic reactions to local anesthetics. One class is more commonly associated with allergic reactions than the other, and the class that is associated with it is esters. And the reason for that is when esters are hydrolyzed or metabolized, they get broken down into a byproduct called PABA. PABA is what individuals are most often allergic to, giving them an ester allergy. The amide local anesthetics are metabolized by the liver, and they're metabolized slower than esters are by the pseudocholinesterases. Now, the way they're metabolized in the liver is by carboxyl esterases and the P450 system and N-dealkylation. Sorry, hard word to say. Things to keep in mind here is that hepatic disease may slow the clearance and thus lead to toxicity. Another thing I mentioned was methemoglobinemia. There's a couple of local anesthetics that are known to be prone to cause methemoglobinemia, and two of those more common ones are amides. So prilocaine and lidocaine, which we'll talk about, I believe, a little bit later. It's the two that form IMLA cream, but they're prone to cause methemoglobinemia, and I put benzocaine on there as well because that's another common one, even though it's an ester. And just as a review, remember, if somebody develops methemoglobinemia, remember that the treatment is methylene blue. Now, whereas esters more prone to allergic reactions because of the byproduct PABA, amide local anesthetics are much more rare in causing allergic reaction. Typically, if somebody does develop allergic reaction to an amide, it's probably more commonly from a preservative like methylparaben than the actual local anesthetic itself. This is one reason why amides are used more frequent than esters because of the decreased allergic reaction risk. But something that we'll allude to later, the amides typically, in general, are more potent than your esters. We haven't talked specifically about any of the local anesthetics in detail, but keep in mind that most of them have multiple uses. So I kind of just went ahead and threw the clinical uses in here. So common things: local infiltration, topical anesthesia, like the IMLA cream that I just mentioned. Obviously for our peripheral nerve blocks, neuraxial anesthesia. But also keep in mind that local anesthetics can be used for arrhythmia treatment and pain management, which we're starting to see more and more with these lidocaine infusions. This is a busy slide, but I threw the picture in there because it shows some of what we just kind of talked about and how it's grouping the amides together, the esters together. It talks about the clinical uses, kind of what we just mentioned in the previous slide. But it also lets you see the common concentrations that are used for each individual local anesthetic, as well as the onset, though most of them say fast onset, which clinically I don't know how relevant that is because that's not what we see. And then the duration, and that's a little bit more accurate of what we see and how we utilize the different local anesthetics. For example, doing a surgical block lidocaine versus bupivacaine. And then the last column to the far right just represents the maximum single dose for each local anesthetic. Now later on in the lecture, I'll put up some more graphs and charts and pictures that kind of do a better summarization of this. One of the fundamental concepts to local anesthetics is their site of action. All local anesthetics will bind to voltage-gated sodium channels. So regardless of where that sodium channel is, whether it's muscle, cardiac, or neural tissue, local anesthetics are going to bind to that sodium channel. Another concept to keep in mind is that for the local anesthetics to work, they have to cross the cell membrane and bind intracellularly to their receptor. Once bound intracellularly, then they can perform their mechanism of action. Now this is where it can kind of get confusing, and there's a lot more depth to understanding of this, but keep in mind that historically not all nerve fibers are affected equally. You have to remember that some nerve fibers are myelinated, some are not. Some nerve fibers have large axons, some have small axons. These few things, as well as a couple other factors, play a role in how the local anesthetics work on those nerves. When working on those nerves and inhibiting the impulses, they can develop what we call a differential blockade because of these factors. Meaning, you can have a sympathetics blocked or affected, but have no effect on motor or sensory. So typically the way it goes, and without going into detail, is you typically get your sympathetic function affected first, then temperature gets affected, followed by touch, pinprick, and proprioception, and then lastly motor function. As for the mechanism of action, once the local anesthetic crosses the cell membrane, it will bind to the alpha subunit of a sodium channel. You may recall that a sodium channel typically has a large alpha subunit and then two smaller beta subunits. Once this local anesthetic binds to its receptor, it prevents an influx of sodium that is needed for nerve depolarization. Thus, if you don't have the influx, you never get the depolarization, you never get an action potential to propagate. Local anesthetics have also shown a greater affinity for activated and inactivated channel states. So therefore, the greatest effect that a local anesthetic can have is when the nerve is rapidly firing. Now, one thing I haven't mentioned yet is that local anesthetics must be non-ionized or unionized, depending on what source you're reading, in order to cross the cell membrane, but then become ionized once intracellularly in order to bind to its receptor. When a local anesthetic is in its non-ionized or uncharged state, it is lipophilic. It is this lipophilic state that allows a local anesthetic to cross a cell membrane. Once that local anesthetic is intracellular, it converts back to its ionized or charged state for stability and binding to sodium channels and its receptors. Now, it's only thought that 1 to 2% of total drug is estimated to cross into the cell. Another important concept to know is the nodes of Ranvier and what must be blocked. So if a nerve is myelinated, it has nodes of Ranvier. In order to decay or stop the transmission of a signal, 3 nodes or more need to be blocked. If it's less, the impulse may jump over the site that's affected by local anesthetic and continue that impulse. When 3 or more nodes is blocked, decaying the transmission, this is what they refer to as serial nodes of Ranvier being blocked. If the local anesthetic is acting on unmyelinated nerve, it is thought that a greater length of that nerve needs to be acted on by local anesthetic to impede that impulse or action potential from progressing. When we talk about local anesthetics clinically, whether you know it or not, we're typically talking about their potency, duration of action, speed of onset, and tendency for differential sensory nerve blocks. Let's start with potency. Potency reflects the local anesthetic's affinity to bind to sodium channels. The potency of a local anesthetic is directly related to its lipid solubility and molecular weight. The onset of action depends on lipid solubility as well as the relative concentration of non-ionized form. So the closer the pKa of the local anesthetic to physiologic pH, the greater the non-ionized fraction that exists. The duration of action correlates with lipid solubility as well. The more lipid soluble, the longer the duration of action. The reason for this is it's less likely to be cleared by blood flow. In addition, it's also more likely to be protein bound, which again will result in a longer duration of action. When it's protein bound, the most common protein for it to be bound to is alpha-1 acid glycoprotein. And you can imagine if it's protein bound, there's going to be a slower elimination as well, giving it a longer duration of action. Thus, increased lipid solubility is associated with an increased protein binding in blood, increased potency, and a longer duration of action. Of the three concepts, potency, duration of action, and onset of action, I think the onset of action is the most difficult to understand. But if you can just remember that the lower the pKa of a specific local anesthetic, meaning the closer to physiologic pH, the more non-ionized form there is, which means it's more readily able to cross the cell membrane, bind to the sodium channels, and perform its mechanism of action, and therefore have a quicker onset of action. One of the factors that can play a role in onset of action is concentration. So let's look at chloroprocaine, for example. Its pKa is 9, so you would not expect it to have a quick onset of action. However, for all of us that have given it, we know that its onset is fairly quick. And the reason for that is its high concentration. 3% is what it's normally formulated as. Remember that chloroprocaine has very low risk for systemic toxicity because it's metabolized so quick, which is one reason we can give it in such high concentrations or dose to overcome its pKa and would otherwise give it a slow onset. For those of you that like tables, here's another table summarizing what we just talked about in the prior slides. Again, it lists several different local anesthetics, their type, whether an ester or amide, their site of metabolism, obviously as we've learned based on whether it's an ester or an amide. Then it also gives you the pKa values, the lipid solubility, and the protein binding percent. Another important concept that is frequently tested on is systemic absorption of local anesthetic. So systemic absorption is proportional to vascularity where it is injected. So vessel-rich tissues will result in a higher systemic concentrations. So this is where you'll commonly see that intravenous is greater than tracheal, which is greater than intercostal, which is greater than caudal, which is greater than paravertebral, paracervical, and so forth as I have listed. Now when it comes to test time, they'll change this order up and expect you to pick the right order from greatest to least or least to greatest. Along those lines, it's also important to know that mucous membranes are weak barriers and will lead to rapid onset of action. So the hurricane spray or benzocaine spray that we use intraoral, if you've ever done it before, you spray it and it works almost immediate. The skin, on the other hand, is the opposite. It requires a high concentration of lipid-soluble local anesthetic. So, as I mentioned in prior slide, Imlacream, it's a combination of lidocaine and prilocaine. This is what you'll commonly see on pediatric patients when they come in as an outpatient or from the floor, and they have this white cream under a adhesive bandage, typically on the top of their hands or in their AC. This is numbing the skin area as well as the subcutaneous tissue for IV placement. Couple things to note on Imlacream is that it can cause a couple side effects like blanching or erythema, but most notably methemoglobinemia. Distribution of local anesthetics based on organ uptake is determined by tissue perfusion, more specifically alpha and beta phases, and this refers to the amount of tissue perfusion. So the alpha phase is your highly perfused tissues like your heart, your brain, your lungs, your kidneys, and then your beta phase is your less perfused tissues like your muscle. It's also important to know that lungs can extract a significant amount of local anesthetic. It's also determined by protein binding. So the more binding, the more that remains in the blood. And lastly, distribution based on organ uptake is determined by tissue mass. Muscle is the largest reservoir for local anesthetic. A few more pharmacokinetic facts. The dose administered is nearly directly linear to the plasma concentration. Also, the more lipid-soluble agents will give a slower absorption rate to systemic concentration. And lastly, low concentrations of potent agents can cause vasoconstriction around the injectate, but at high concentration, they'll yield vasodilation. The exception to this is cocaine. It will cause vasoconstriction regardless of the dose or the concentration. This is another great chart of local anesthetics showing their characteristics and how they compare to each other. So instead of going through the whole chart, it's here for your review, especially for those that learn better by looking at charts. But let's just look at a few things. Let's look all the way at the bottom at chloroprocaine. Look at its pKa value. It's 9, which is on the high end, probably the highest of all the local anesthetics. With that, you won't expect much of it to be in the non-ionized form. Its onset, therefore, is going to be much slower than something that had more of a non-ionized form. Also, you can see that its lipid solubility is pretty low compared to other local anesthetics like bupivacaine. Again, so its onset's going to be slow. Not only that, its potency is going to be low. And then if you look at the protein binding and duration, it doesn't have much protein binding, if any, so its duration is going to be short. So then, why does this work so quick and give us such a dense block up on OB? Well, you got to remember, like we mentioned before, its concentration that we use is 3%. So this overcomes these characteristics. Now let's compare bupivacaine and lidocaine, two local anesthetics that we commonly use on acute pain. So say somebody came to you and wanted a surgical block. It was a surgical block that they need to work relatively quick rather than giving it time to set up. So what would you use, lidocaine or bupivacaine? Well, knowing what we've seen clinically, but looking at the chart, there's a couple things that we can deduce. First, lidocaine's pKa is a little bit closer to physiologic pH compared to bupivacaine. Therefore, more of lidocaine will be in the non-ionized form compared to bupivacaine's non-ionized form. And therefore, it will cross over more readily and have a quicker onset of action. Lidocaine also has less protein binding than bupivacaine, so its duration of action is going to be less than bupivacaine, which again, we see. We all should know that lidocaine will have about a 90-minute time frame for duration, whereas bupivacaine, depending on the amount that you gave, can be 6 to 12 hours. Lastly, lidocaine is less potent than bupivacaine, so typically we'll use a 1% to 2% concentration, whereas you think about bupivacaine, we're usually using a 1/4% or 0.5% concentration. So take your time, review the local anesthetics, and just become familiar with the generality of the characteristics of each local anesthetic. This is a continuation of the esters from the previous slide. Again, this is another chart organizing the characteristics of the local anesthetics. I like this chart a little bit better because there seems to be a more accurate representation of the local anesthetics as far as onset and duration that we see clinically. But again, the chart includes the pKa's, the lipid solubility, the potency, and the protein binding. So again, take the next few minutes, review this slide, become familiar with the generality of each local anesthetic. If you go back to the question I just previously asked about if we were doing a surgical block, what would you use, lidocaine or bupivacaine? By looking at this chart, you can look at the onset. Lidocaine is fast, bupivacaine is medium. So if you need to do a surgical block and they needed to go immediately, I would go with lidocaine because you can see that it's going to work faster than bupivacaine. What you need to consider is the duration. Is this a procedure that can get done in 90 minutes, give or take, or do you need to add bupivacaine with it? So not only do you get the fast onset time from the lidocaine, but then you get the lasting effect from the bupivacaine. I included this chart of the local anesthetics because it includes the maximum dose. This is a common question on tests that you have to calculate out, and this shows what your maximum dose for the common local anesthetics would be. It also gives you the duration in hours compared to just short, medium, and long to give you a little bit better understanding. As far as the concentration, techniques, that has been seen on prior charts that I put on a previous slide. I will point out that one local anesthetic that we don't use very often, but is on this chart, is mepivacaine. And one thing to kind of notice is that mepivacaine is very, very similar to lidocaine in its characteristics. This slide shows some of the more common local anesthetics and their clinical characteristics. There's a few things I want to point out. One is prilocaine can cause methemoglobinemia. Remember that bupivacaine is a racemic mixture of the R and S enantiomers. The L-bupivacaine or levobupivacaine is the S enantiomer of bupivacaine, and its benefit over bupivacaine is that it causes less cardiotoxicity as well as a decrease in motor blockade. Ropivacaine is even better than levobupivacaine in causing less cardiotoxicity and a reduced motor blockade. Benzocaine, as I mentioned earlier, is a spray that I used after my transplant when I had my bronchs done, and you'll commonly see me use it for awake fiber optics. Lastly, cocaine would be a good option if you were doing a nasal intubation, because not only does it provide the anesthesia that you need, but it's a profound vasoconstrictor. If using cocaine, you need to be vigilant about its side effects and toxicity, especially in patients with cardiac disease. Now that we covered the pharmacodynamics, pharmacokinetics, the mechanism of action, site of action of local anesthetics, let's talk about some additives that are commonly found with local anesthetics. The first is epinephrine. Epinephrine has been shown to prolong blockade time, enhance intensity of the block, and decrease systemic local anesthetic absorption. It's known to act on alpha-2 receptor and cause direct analgesic effect. If using epinephrine as an additive, you need to be cognitive about the variable concentrations. At higher concentrations, it may lead to clinically concerning hypertension, tachycardia, and possible tissue and nerve damage secondary to arterial constriction and reduced blood flow. One important concept is to remember that there is little to no effect if a local anesthetic is highly protein bound, like bupivacaine. Another very common additive is sodium bicarb. Bicarb is an alkalizing solution. Thus, it increases the pH, thus yielding more non-ionized local anesthetic. This in turn increases the rate of onset by 3 to 5 minutes. The duration of action may be compromised without adding a prolonging agent like epinephrine. It can also decrease pain with subcutaneous injection. One place we commonly see this is up on OB. When we dose an epidural for C-section, we commonly use lidocaine that contains epi, and then we would also add the bicarb. Another thing to keep in mind is that excessive alkalinizing agents may lead to solution precipitation, as most agents are in slightly acidic preparations. Another additive that is always being looked at is opiates. The discovery of peripheral tissue opiate receptors led to studies investigating their use in peripheral nerve blocks. However, results were not promising for routine use. On the other hand, CNS receptor targeting for opioids with spinal and epidural routes have consistently resulted in improved analgesic profiles. Recently, there's been a push, especially from ASRA, about using buprenorphine in peripheral nerve blocks because of the positive results. I would expect this to become more common practice in the near future. A few other additives to mention include your alpha-2 agonists like clonidine. Clonidine has inhibitory effects on your A and C pain fibers. It has also been shown to increase the duration of action up to 2 hours. And of course, it's recommended to use preservative-free solutions. Lastly are your steroids. You have triamcinolone and dexamethasone as your more common agents used as additives. Triamcinolone is used more in chronic pain injectates for neuritis type pain. Dexamethasone is commonly used to prolong peripheral nerve block times. As far as dexamethasone goes, studies have shown that IV routes are comparable to including dexamethasone in your peripheral nerve block injectate. And lastly, solutions commonly have preservatives, so if you're going to use a steroid, make sure it's preservative free as well. The common preservatives include phenol and methylparaben, which can be neurotoxic. This slide summarizes the additives I just previously mentioned. It includes a couple others that I did not, like ketamine, which is a weak local anesthetic property. Dextrose is another additive that we could have mentioned. This is commonly seen with our spinal marcaine, which has dextrose in it, making it hyperbaric. And lastly is hyaluronidase, which is in bulbar blocks, which we don't do, at least at UK. Local anesthetic toxicity is another important topic to briefly mention. Systemic circulation of local anesthetic plasma concentrations affects the sodium channel-rich central nervous system and cardiovascular system, with the central nervous system being more sensitive. Symptoms commonly manifest in ascending order from CNS excitation like tinnitus, metallic taste, circumoral numbness, muscle twitching, seizure, to CNS depression like coma, lethargic, respiratory arrest, and then proceeding to the cardiovascular effects like EKG changes and asystole. The symptom progression is due to increasing plasma concentration affecting subtypes of sodium channels relative to the drug affinity. Again, remember, there are multiple different types of sodium channels, and the local anesthetics act on these channels different. So like bupivacaine, remember, it's very cardiotoxic compared to other local anesthetics. This slide shows the relative potency for systemic central nervous system toxicity by local anesthetics and the ratio of dosage needed for cardiovascular system to central nervous system toxicity. So when looking at the chart, the relative potency for CNS toxicity is highest for bupivacaine at 4.0, and its lowest is for procaine and chloroprocaine at 0.3. This is why I mentioned earlier that chloroprocaine has a very low risk for systemic toxicity. Lidocaine is at 1, which is lower than some of the other more common local anesthetics that we use every day, like ropivacaine, bupivacaine. And then you have your CVS to CNS ratio. When looking at this, the easiest way to understand this is the closer the value is to 1, the more likely it is to cause cardiovascular toxicity in addition to central nervous system toxicity. If this ratio is higher, say for lidocaine at 7.1, it is much more likely to cause central nervous system toxicity than it is to cardiovascular toxicity, meaning it will require a lot more plasma concentration of lidocaine to reach that cardiovascular toxicity. The previous slide confirms that cardiovascular toxicity traditionally occurs at higher plasma concentrations than when the CNS symptoms manifest. For instance, a seizure typically occurs at 10 to 15 micrograms per milliliter versus cardiovascular depression, which occurs at greater than 25 micrograms per milliliter. As I alluded to before, different local anesthetic agents have different affinities for the central nervous system and cardiovascular system sodium channels. Toxicity can also manifest as pulmonary artery hypertension, typically which is seen with increasing local anesthetic concentrations. Any local anesthetic can cause toxicity, but it's bupivacaine that may be the most worrisome. Bupivacaine has the highest affinity for cardiac sodium channels, specifically the R enantiomer. And due to the R enantiomer's stereospecific shape and binding properties, it additionally has a higher affinity for resting and inactivated sodium channels. Bupivacaine also has a slower dissociation from the receptor, further complicating its effect on normal cardiac sodium conductance. EKG manifestations may show PR prolongation and or widening of QRS before asystole occurs. Anybody administering local anesthetics should be able to identify and be able to treat local anesthetic systemic toxicity. Before the discovery of intralipid, the only surviving patients from local anesthetic cardiovascular collapse were those placed on cardiopulmonary bypass. The signs and symptoms of LAST include CNS excitation, followed by CNS depression, followed by cardiovascular depression. The treatment for LAST is a 20% intralipid emulsion that is dosed at 1.5 to 2 mL per kg bolus. This may be repeated 5 minutes after initial bolus if no return of spontaneous circulation. You can also start an infusion at 0.25 up to 1 mL per kg per minute until return of spontaneous circulation occurs. You can continue this infusion for at least 10 minutes post ROSC. The max recommended dose is 10 mL per kg, but has been discussed at conferences up to 20 mL per kg or more. The administration of intralipid is pivotal in the treatment of LAST, but at the same time you will want to be treating other things like hypoxia and acidosis. Both of these can make the situation worse. You'll want to give benzos for seizures, and you'll want to reduce your epinephrine dose because of the arrhythmogenic nature. Amiodarone is your first-line antiarrhythmic, and you'll want to avoid class 1A sodium channel blockers like lidocaine. The other things to avoid include calcium channel blockers, beta blockers, and vasopressin. And obviously, you'll want to monitor these patients for an extended period of time. The risk of local anesthetic toxicity can be categorized in relation to the injected drug, the technique, and the patient. Those risks related to the drug can include things like your CVS to CNS ratio, which we mentioned before. As far as the risk related to technique, well, that's a whole different lecture. For this slide, we'll focus at who is at risk. So the common people or individuals that are at risk are 1, your parturients. 2 would be anybody with low levels of alpha-1 acid glycoprotein, which could be for a number of reasons, such as in a parturient or in somebody with renal disease. And 3, any reason for a decreased drug clearance. Again, renal disease, liver disease, anything that's going to impede the clearance and metabolism of that local anesthetic will put somebody at risk. Lastly, we'll end with a slide on Exparel. This is a drug that's been out for a little while now, but there's still not a lot of research or data out there. The concept behind Exparel is to do a single injection of this liposomal bupivacaine that then will have an effect for 72 hours. Now it comes as a 20 ml bottle at 1.3% solution. It can be diluted to a very large volume, and as I mentioned, its advertised effect is for 72 hours. And I'm not saying that there aren't any, but I have yet to see any reported toxicity cases yet. So I think over the next few years we may see the development of Exparel into something big, or it may kind of flounder and kind of go to the wayside. Only time will tell. Well, that concludes this lecture. I hope that it gave you a good, thorough review of local anesthetics. I hope that you all continue to read and study until this pandemic passes. See you all soon. Take care.